This is Peter J. Pollack, MD, with another Medical Practice Trends podcast, and our guest today is Dr. Stephen Schimpf, internist and former CEO of the University of Maryland Medical Center and author of The Future of Healthcare Delivery. Welcome, Steve.
Thanks very much for having me, Peter.
So our topic today is on high-deductible health insurance. Years ago, we paid for routine medical care, such as when we took our kids to the pediatrician for a routine checkup, and we paid for most prescriptions. But today, if we have employer-sponsored insurance or Medicare, which is what most people have, everything's paid for. So insurance today is sort of prepaid rather than catastrophic. What's happened? Is this good or bad? And what are your thoughts on high-deductible health insurance?
Well, I think we should back up for a second and just point out that today most of us have what I would call prepaid medical care, meaning that we look at our insurance as meant to cover everything, whether that's routine stuff, immunizations, even lifestyle drugs. It covers just about everything, as opposed to the way insurance typically is in other settings. You mentioned in an earlier one of our podcasts that our car insurance, for example, you can have a high deductible or a low deductible, your choice. If you have a high deductible, you pay less. If you have a low deductible, you pay more. But really the point of it is that your insurance is for the catastrophic, for the time when your car is really badly damaged, with the idea that you'll pick up the cost for a minor fender bender. This is the way health insurance used to be as well. But we've morphed from that over the years. A little bit more has been added all the time until now just about everything is covered by most of our health insurance. Now, we do have some deductibles and some copays, but they're usually relatively small. So the idea of the high deductible policy is that in return for having a much lower premium, in effect, let's call it self-insurance, you accept that you'll pay maybe you say $1,000 a year or even more, and in return you get that lower premium. It's a trade-off, but I think it's a valuable trade-off.
Now, we spoke a little earlier about the rising healthcare costs in this country and how a lot of that, some experts feel, is the fact that since everything is covered, the patients don't realize how much everything costs, so are likely to go along with getting expensive tests and services done because, after all, they're not picking up the tab. Even if it's being deducted out of their paycheck, somebody else is paying for it.
Well, that's right. And I was looking at some information, I think it was on Aetna recently, and they had, for a number of years, I think they still have it, but they were looking at their data from a number of 3 or 4 years of people who had a high deductible policy versus a more standard policy. The bottom line was that those who had the high deductible policy, there were fewer claims paid for those on the high deductible policy, which suggests that they're challenging their physician, they're asking more questions, they're wondering if this test is necessary or if there's a generic drug that could replace the patented drug and so on. So then a criticism was raised and said, well, okay, if you have a high deductible, then you're not going to get preventive medicine done. That's been why in the health reform bill, Congress inserted the requirement that there be no deductibles or copays around preventive medicine. But anyway, back to the Aetna data, they had it set up that you could have a high deductible, but the insurance would still pay for preventive services. And in that situation, there still was a big savings. So it seems to work. And I know it from my own experience, which I related a few of them to you earlier in an earlier podcast. And I know it from talking to a lot of patients and a lot of physicians that the high deductible concept works well.
Another trend, which maybe goes along with that, is one of increasing premium services that may be allowed to be balance billed. We may be starting to see more of this even in Medicare. Is that sort of the same feeling or the same philosophy that if the patients are responsible for part of the cost, that it may drive utilization down?
Certainly we'll encourage you to ask questions. Let me give an example. Let's say somebody has an ulcer. And we now know that most ulcers are caused by Helicobacter pylori bacteria, and you can eradicate that with a combination of antibiotics and an acid suppressor, a proton pump inhibitor. But it's very important you take all 3 drugs for a full 2 weeks. The antibiotics themselves are fairly inexpensive. Amoxicillin and clarithromycin have been around for years, so they're not terribly expensive. And the proton pump inhibitors, there are some that are over-the-counter, and there are some that are still branded and patented. So those are expensive, and over-the-counter is less expensive. But if you as a patient now, your doctor says, look, you got to take these 3 drugs, and here's a special prepackaged arrangement which has all 3 drugs in the package, and it's designed very nicely so on day 1 you know to take this one and this one and this one in the morning and this and this and this in the evening and so on, and here's all 14 days. That package costs about $350. Well, to cure ulcers, which used to be a chronic problem for life, that's not a bad deal, $350. You could, however, buy the 3 drugs separately for about $250. But you as the patient won't want to do that because with the first one, the $350, if it's typical today with employer-sponsored insurance, you'll pay $15 or $20 copay, and your insurance pays the balance. So if you got the 3 drugs separately, even though it would cost $100 less overall, it's going to cost you more because you're going to have 3 $15 copays or $45 instead of 1. So you'll tell your doc, hey, give me the combination pack. But thirdly, you could get the over-the-counter drug, which you can pick up in a supermarket or Walmart for about $28, but you have to pay the whole $28. You'd rather get the more expensive drug, the $150 drug in this combination, and pay the $15 copay because $15 is less than the $28. So our incentives are, well, they're just messed up in this country.
And there's more of an incentive for the pharmaceutical company to sell the brand name package.
Well, yeah, it helps them continue that, and good for them. I'm a capitalist. I'd like to see the drug companies do well and continue to reinvest in bringing out new drugs and all. But just our incentives are wrong, and they need to change. That's why a high deductible for everything just makes good sense, because if you had the high deductible, you'd certainly go with the least expensive arrangement.
And do you think that should be applied to Medicare as well?
Well, I do. And in fact, I'm practicing what I preach here. I'm on Medicare. So I have a Medicare, of course, and then I also have a Medigap policy. So for my Medigap policy, I have a $2,000 deductible. So the way Medicare works, of course, is it pays a portion, and then your Medigap policy picks up the balance. And so I pay that balance until I get up to $2,000, and I'm happy to say I haven't been sick and haven't had to pay that kind of money, but I would have to if something came up. It makes a difference, though. I saw my internist for something not too long ago, and he said, well, maybe we should get an MRI. And I said, well, you think we could just, and he was also going to give me a medicine, and I said, well, how about we just take the medicine for a while, and then if it doesn't work, we get the MRI. He said, well, I guess that's okay. And I questioned him. I don't want to say I challenged him. Maybe that's too strong a term. But once he realized that I was asking, one, out of interest, do I really need it? But also because he realized that, hey, this guy's going to have to pay for that, or part of it. So it makes a difference.
And that's an illustration of the point you make that in addition to reducing or potentially reducing the overall cost of care, that you're also bringing back that typical or traditional professional relationship between the provider and the patient instead of making it a relationship between the provider and the insurance company.
Well, exactly. You know, right now, the insurance company sets the fees, and the insurance company is largely the customer. The patient is not the customer because we're not paying directly, and it changes things subtly. I just gave you the example of a subtle change with my own physician. He knows that I'm paying the bill, or at least my part of the bill, and he's responsive to that.
Is that sort of the antithesis of that, though, the capitated plans? And it seems like there may be more and more of a trend of these types of arrangements. Doesn't that kind of flip that back to where the relationship is back between the provider and the insurance company?
Well, I think you make a good point, and I don't have a good response for you, to be honest. I've seen capitated plans work well, and I've seen them not work too well. You were talking about the primary care physician being the gatekeeper in a capitated plan. And although that works and it's effective, patients don't like it. They don't like the idea that I have to go and say may I in order to go see the orthopedist, for example, or the ophthalmologist or whoever. So how we'll get back to that, I'm not sure, because patients don't like that aspect of capitation.
Well, Steve, if someone wanted more information about your writings or your book, The Future of Healthcare Delivery, where can they get that?
They can go to Amazon.com or BarnesandNoble.com, Or if they just would like to get some information or check for endorsements or a video, they can go to my website, which is www.medicalmegatrends, one word, medicalmegatrends.com.
Okay, well, thanks so much.
And I thank you.